started off, I'm a general pediatrician by training, and have been working in the a clinic on chronic fatigue syndrome, where we identified the fact that many of these patients had orthostatic intolerance as an important part of their syndrome, recognized that many of these kids also had Ehlers-Danlos syndrome and Chiari. So I think by definition, I live inside of Hal's Venn diagram. So I'm going to talk clinically today about some patients that might complicate your thinking about recovery or leading up to Chiari malformation. I thought I'd begin with an overview of orthostatic intolerance and present a patient for whom this was a big factor in post-decompression symptoms that confused people regarding the quality of her repair. And then a couple who had very prolonged prodromal presentations with fatigue and orthostatic intolerance before they were recognized to have Chiari malformation. The definition we use for orthostatic intolerance comes from Phil Lowe's group at the Mayo Clinic, and it really refers to a group of clinical conditions in which symptoms worsen with quiet, upright posture, getting up and maintaining that posture, and are ameliorated but not abolished by recumbency. Big challenge physiologically is we drop about 500 to 700 mils of blood into the lower half of the body when we stand. And the normal response to that is that you get a drop in arterial pressure, unloading of the baroreceptors, and as Dr. Long was mentioning in his talk, this all goes through the important brainstem centers. The end result in healthy people is a big increase in the outflow of sympathetic nerve activity, which results in about a 10 to 20 beat increase in heart rate for most of us, an improvement in stroke volume. But the biggest change is that you vasoconstrict better, shunting the blood back up to the heart and brain. And when that doesn't occur well, this is the range of symptoms that you'll see. And on the left, you see symptoms that are easily understood to be related to inadequate cerebral perfusion. So lightheadedness, syncope, poor concentration or brain fog, which we've heard about a lot this morning, headaches and blurred vision. Fatigue and exercise intolerance are seen in just about every form of chronic orthostatic intolerance. We don't understand the mechanisms by any means. On this side are symptoms that are often related to the secondary increase in catecholamines that we see in the orthostatic intolerance conditions, including chest pain, which is very common, palpitations, tremulousness, and an overrepresentation of anxiety in this population, which may lead many of our colleagues to discount their symptoms. The common forms of orthostatic intolerance are POTS, which we've heard about, and that's defined as you go from supine to standing as a 30 beat increase in heart rate for adults, and for adolescents it needs to be a 40 beat increase. But it's not just the tachycardia. It has to be accompanied by reproduction of the typical symptoms. If you get a heart rate above 120, that also counts as POTS. The other thing, though, that we first described was neurally mediated hypotension. This is the same thing most of us learned about as vasovagal syncope in medical school. It goes by a number of synonyms, which confuses everybody: neurally mediated syncope, neurocardiogenic syncope, vasodepressor syncope. We liked the term neurally mediated hypotension because not all of our patients with this pattern on tilt table testing had experienced syncope before, and we thought that we needed to really focus on the physiology rather than the event. This is a medical student at Hopkins who had been a very active aid worker in Tibet, started in our medical school, and was immediately much more lightheaded and had increasing syncope and pre-syncope, such that she failed her first year. She just couldn't maintain herself. We noticed that she'd had recurrent patellar dislocations and frequent pneumothoraces, so it suggested a connective tissue abnormality. Tilt tested her, and as she went from supine to upright, her systolic and diastolic blood pressures were okay for a bit. Heart rate went up about 9 beats, and then suddenly at the 6-minute point, she became syncopal. She responded to some medications directed at that, and is now, and in fact was able to do her surgical clerkships. And that was her main worry when she came to see me. And at the end of when I saw her back in follow-up, she said that she now wanted to be a surgeon, which, depending on your perspective, means that we also improved her cognitive dysfunction. So neurally mediated hypotension is the most common cause of syncope at any age, but it's also more common in women, which is relevant to today's discussion, in young people, and those who start off at the bottom end of the blood pressure distribution curve. It can be triggered by infection. Family members are often affected, although we don't know the genetic contributors to that. And because their physical examination, routine lab testing is normal, they used to be told that, you know, there, dear, what's wrong at home? There wasn't much serious consideration given to this until tilt testing came along in the late 1980s. The hypotension isn't picked up by standard 2-3 minute orthostatic testing in the office, and you need prolonged tilt testing. One of the interesting things that was discovered back in the 1920s is that if you faint, you can be exhausted and tremulous for 72 hours afterwards. And part of our thinking was that if you get recurrent minor degrees of lightheadedness, you're building up a debt of fatigue that you just can't sleep off. The other form, which is sometimes incorrectly thought to be the only form of chronic orthostatic intolerance, is POTS. And this has been described back in the Civil War era as something that was termed irritable heart or effort syndrome, or in Osler's day, neurocirculatory asthenia. Like the conditions we've been talking about, especially hypermobile EDS, there's a very strong female to male predominance. It's uncommon in young children, and importantly for the surgeons in the audience, this can have an onset that occurs after surgery, and I'll suggest to you one of the reasons why that might be the case. The symptoms can be really disabling, and we've seen a huge increase in our recognition of this problem in the last 10 to 20 years. The physiology is quite heterogeneous, and you get a number of people trying to classify it one way or the other. One term is that there's a neuropathic form where it's thought that there's a patchy denervation of the sympathetic nerve fibers in the legs. Their norepinephrine levels are above 600 when they stand. And then others have termed it a central hyperadrenergic form where the norepinephrine goes above 1,000. But all of these patients are hyperadrenergic to some degree. Hypovolemia is uncommon. They have very odd renin-aldosterone ratios, so they don't produce enough aldosterone. Joint hypermobility, as I'll show you, is quite common. Deconditioning is also common and aggravates any underlying problems. And then there are associations between POTS and mast cell disorders, so those are also found in those with the EDS. We were seeing patients in clinic and noticed that we had a couple of people with EDS. So we decided in the late 90s to start looking more formally. And you heard from Allison that the EDS incidence is supposed to be 1 in 5,000. So we looked at our next 100 adolescents in the chronic fatigue syndrome clinic and found 12 subjects. So that was a highly unexpected and significant difference. They were split between the classical and the hypermobile type, mostly female, and all of them had some degree of either neurally mediated hypotension or POTS. We then thought, well, I wonder if the milder forms of joint hypermobility are also more common in this population. And so we looked at a group of healthy kids in the yellow, did a Beighton score. 4 is the cut point for joint hypermobility. And 20% of the healthy kids were 4 or higher. These are the dancers, the gymnasts, the healthy kids. They didn't really have true medical problems. This was just a trait. But if you look at the distribution curve for our CFS patients, very different population. About 60% of them met criteria for hypermobility. And since then, Rodney Graham's group, as Fraser mentioned, have looked at dysautonomia in the hypermobile population and found it. And probably the best study so far on this topic, linking hypermobility and orthostatic intolerance, was just published earlier this year from the Belgian group, where they compared a group of autonomic symptoms in hypermobile type and classic type EDS. And the hypermobile patients had more of the general autonomic symptoms than did the classical type. Here they're comparing the hypermobile type to healthy controls, and you can see really the vast differences in a number of autonomic symptoms. If we look at a brief summary of the physiologic changes in these patients, whether it's NMH or POTS, they have three main problems. One is that when they stand, they pool more blood in the periphery. They seem to have a defect in their ability to vasoconstrict, possibly because these lax connective tissues are leading to too much compliance in the dependent vessels. They have a reduction in intravascular volume in the beginning, so they don't tolerate extra dehydration stress. And when you stand them or tilt them, they get an increased sympathoadrenal response. And David Goldstein at the NIH thinks that the reason you get POTS in some or hypotension in others relates to the relative proportion of norepinephrine, which is a better constrictor, vasoconstrictor, and epinephrine. So POTS patients typically have higher norepinephrine levels, and the hypotensive patients get more of an increase in epinephrine. Another thing that we've seen is, and that everybody sees, is a tremendous degree of dependent acrocyanosis. So here's a girl who had not been able to finish her second year of college due to fatigue and lightheadedness. We stood her up in the clinic leaning against the wall, and this is what her hand looked like after 3 minutes. That's my hand behind it, just for a color contrast. And then a minute or so later, I put my fingers on her leg, stepped back, picked up the family camera that was sitting there, focused it, messed around, then took this picture. Still no capillary refill. And if we saw that in one of our ICU patients, we'd be really concerned about their circulatory function. And this is what these folks are like day to day. One of the findings in the orthostatic literature that relates to postoperative recovery and why these problems might get worse after surgery is shown here. There has been a lot of interest in looking at orthostatic intolerance in astronauts. So NASA has funded a lot of this research because the astronauts, as they come back to zero gravity, have terrific troubles staying upright with mental fogginess and lightheadedness. So they did these studies that I think Hal might have trouble getting through his IRB because they had them in complete bed rest for 200 days. And I'm not sure how you'd keep people in a study like that, but interestingly, in the first 2 weeks, what they were seeing was up to a 15 to 18% loss of plasma volume. So inactivity and bed rest will aggravate any form of orthostatic intolerance. And that's the kind of thing you're going to see after surgery. Shifting a bit, we know that there have been a number of papers talking about syncope as a presenting feature of Chiari malformation or POTS in association with syringomyelia. People debate how commonly these occur. But I thought I'd go now into some cases. So here's a girl who got orthostatic intolerance worsening after her decompression. She's a 15-year-old whose father is a member of our faculty at Hopkins, and she'd been quite energetic and active. She started getting headaches with some fatigue, and the symptoms fluctuated for a few months. By December of 2005, she had an increased frequency of the headaches, had some migraines with some paresthesias, and often had this need to lie down. Her first syncopal episode occurred in March of 2006, and after that she was unable to attend school because of the intensity of her headache. That led her physician to send her to one of the neurosurgeons who identified nystagmus, and she had an abnormal Romberg test, and she had a Chiari malformation with 3 to 4 millimeters of tonsillar descent. So she had a decompression performed. And initially, her headache was way better. She just felt great. Then this was succeeded by a duller bitemporal headache, different than her Chiari headaches, with some vertigo. She was seen by our ENT folks, and they didn't think she had their kind of problem, that the vertigo was from migraines. So she was sent to the pediatric neurologists who thought, yeah, this was migraine. But she didn't respond to any of the standard migraine drugs, and they even went as far as giving her acupuncture and a trial at a modified ketogenic diet. So I got asked to see her as a secondary opinion. And at that point, she had headaches on most days, usually not starting right in the first thing in the morning, but after she'd been upright for a period of time. And once they began, they were present all day. They were worse in a hot environment, and she would get visual blackouts, losing vision several times a day for brief periods. She didn't really endorse a lot of lightheadedness, but with a hot bath, yeah, that would make her lightheaded. She didn't feel sharp mentally and had to reread her texts frequently. And when I saw her, she was quite pleasant, but I thought a lot slower in her responses than you'd expect for really a top student. And her exam was pretty normal. Her reflexes were good. Her surgery had cured her nystagmus. She had a little bit of neck muscle tightness in the posterior part of her neck, just below the scar. We did a standing test in her, and so she was supine for 5 minutes, and heart rate and blood pressure were fine. With standing, she had about a 38-beat increase in her heart rate, which wasn't quite meeting the criteria for POTS, but she had reproduction of mental fog and fatigue. And I think her dad, who was there at the time, was thinking, what in the world is this joker doing? There's not much happening here. Let's get on with it. Then suddenly, at the 9-minute point, she got really hot, which is probably from an epinephrine surge, worse headache, nausea, had to sit down due to presyncope, and we didn't get her last standing blood pressure. But when she was supine, right afterwards, she had dropped down to 88/40. So she met the criteria for the neurally mediated hypotension. Back to the diagram I showed you before, the way we treat this is with vasoconstrictors to improve the increased pooling, volume expanders, and things that block catecholamine effect. So in her, we began with salt tablets, and that led to fewer headaches. We then added Florinef, which helps you retain sodium, and she only tolerated a fairly low dose of that. We sent her to a physical therapist, and Mike will tell us more about this in a while, but that helped some of her neck muscle tightness. We added Midodrine a bit later as a vasoconstrictor, and she had a good response to that, and at that point was able to participate on her summer swim team. Off she goes to college, functioning well, getting good grades, but we noticed that she's a little bit more responsive to academic and social stresses. That responded nicely to a pretty low dose of a beta blocker. And in the past 4 years, she's been thriving. She just completed a big NIH laboratory internship, and she's applying to medical school. So that is somebody who I think people might have confused with somebody who was having postoperative complications, but really it was the exaggeration of her orthostatic intolerance in the period following surgery. The second patient I want to show you is a boy who got progressive fatigue and orthostatic intolerance as very early features, and the Chiari malformation did not announce itself until later. So this boy was active, typical teenage kid who was a very good athlete. He swam at the same club as Michael Phelps. But he noticed that that fatigue started around 15, and the first indication was not that he was terribly wiped out, but just that his times were slower in swimming, and that after a workout he'd get more tired. 4 months later, as this progressed, he had to stop both sports. He noticed that he was exhausted with orthostatic stress, like a hot shower. And he was seen because of all this by a neurologist who felt that his examination was fine and the brain MRI at the time was normal. He had a Beighton score of 3, so he didn't meet full criteria for joint hypermobility. When I saw him, he had an initial 44-beat increase in his heart rate, along with a variety of symptoms being provoked. He'd often complained that his legs were weak with standing. And his heart rate continued going up past the 10-minute point of the tilt test, and then suddenly he had this typical vasovagal response. So he had both forms of orthostatic intolerance. And initially, he improved a bit after, Yeah, that's it. Anyway, he improved a bit on some stimulants, and extra salt. That's it.
Yes, sorry.
But never really got back to normal. And so 18 months after his symptoms started, he was still attending school, pushing through, but was tired every day and felt weighted down was his term. He tried to participate in sports, but the only thing he could do was be the goalie in the lacrosse games, really not moving much, and he was exhausted for 24 hours after the game. Over the next 6 months, he really did worse, and so when he came back in at the 2-year point, we noticed some fine nystagmus on lateral gaze and a little bit of a resting tremor. Those were new findings. He continued to decline and reported that neck extension made him feel weak and lightheaded. And one of the interesting things he was doing was on a scaffolding, he was painting some design on the ceiling of his bedroom. And during that time, he had 4 episodes of stool and urinary incontinence. So even a general pediatrician is starting to think of Chiari malformation. He started having some trouble swallowing, and a little bit later had rotatory nystagmus, decreased facial sensation, and on repeat MRI had a 7-millimeter tonsillar descent. So he had a very good decompression, so much so that at the end of the first week, 7 days after surgery, he decided to go off to a baseball game at his high school, which was probably way too much upright activity way too soon. And so the next day he was really in bad shape with emesis and headache. He settled down with a bit more rest, but ultimately a year later he was found to have a cerebellar prolapse. And that seemed to do the trick. After the cranioplasty, he had resolution of his nystagmus, and he was able to swim for his college team. We all have patients who make excellent decisions in life. This young man decided to become a roofer, which is exactly what we'd all want him to be doing, climbing ladders. But he actually now owns a company with several franchises. He's probably wealthier than anyone in the room at 35, I think. The last patient is somebody who presented with a very long prodrome of symptoms. She'd been well until the age of 16, started getting neck and upper back pain. She thought she'd twisted something in one of her exercise workouts. Started getting fatigue that was worse with sitting in school, standing in line, or shopping. And that's another key historical feature. If you get a teenager who can't go to the mall and doesn't like to shop, they've got an organic problem until proven otherwise. She would get occipital headaches only after prolonged sitting. Lightheadedness was infrequent initially, and because of her neck pain, she was seen by a neurosurgeon in Richmond and thought to have slightly brisk reflexes, but otherwise normal, and the MRI was interpreted as being normal. When we saw her, the only thing on the exam that was remarkable was that she was very hypermobile with a Beighton score of 7 out of 9. We stood her up in the clinic, and that provoked not only her lightheadedness, but some of her back and neck pain. So we referred her for more formal tilt testing, and I think you can see again here, she did pretty well for about 10 or 12 minutes, and then suddenly blood pressure plummeted down to about 30 systolic. She initially responded to salt and fluids and methylphenidate. Off she goes to college, and she felt good on 5 out of every 7 days and actually felt about 90% of normal on those days. Then at age 20, after a flu episode, she got a big increase in her lightheadedness with increased occipital headaches, achiness, and other symptoms, and then started reporting that coughing was making her headache worse. She had a couple of episodes of choking each week, and on repeat exam now had nystagmus on lateral gaze that would get worse with neck extension, which is something I learned to do from Dan Hafez, one of Dr. Long's trainees, I believe. She had a reduced gag reflex, 3+ reflexes, and now a positive Hoffman sign. And on the exam had an 8-millimeter area of tonsillar descent. And after the decompression, the nystagmus improved, and her wellness score went back up to 80, and her orthostatic intolerance was much easier to treat. So I thought she was really quite an extraordinary patient, because if she did have the Chiari all along, it was missed. The findings didn't appear until much later, I think she raises some points about the interaction between the orthostatic intolerance and the symptoms. So just to conclude, I think we know that there is an association with syncope, but non-syncopal orthostatic intolerance can also be an early manifestation of Chiari malformation, sometimes with this prolonged prodrome before the classic features emerge. Improvement in orthostatic symptoms after surgery suggests that something about compression of the spinal cord is more than just an experimental cause of autonomic dysfunction. The abnormalities we see likely don't cause orthostatic intolerance in all patients, but and there may be shared risk factors for both Chiari and orthostatic intolerance that could include the connective tissue laxity, given that joint hypermobility and EDS are both more common in each condition. So I'll end there. These are just some of the people who've helped us do our work so far.